And thanks a lot, sir, for giving me this opportunity. So I'll be addressing six of these important abstracts dealing with the colorectal carcinoma. And first would be the most exciting one, where we have discussing PD-1 blockade as curative intent therapy for mismatch repair deficient locally advanced rectal cancer. I think this is the miracle drug, which is at least projected as a miracle drug. So this trial should be known to everyone. So in this, they had taken MMR deficient rectal cancers, which account for 5 to 10% of local cancers, which was either stage 2 or 3, and they had actually randomized them to dostarlimab, and then they have seen whether the patient had residual disease or clinical complete response. If residual disease was there, then this patient needed more of a treatment in the form of chemo-RT. So there were 30 subjects in this, and the primary objective was the overall response rate and PCR. So response criteria they had assessed clinically as well as on MRI to see how deep the response was. So these were the break of this patients: 67% female and 33% male, and T3 T4 lesions were 78, and T1 T2 was 22%, and most of them were node positive, as far as highest 94%. And if you see the MLH, MSH, and all these status, then 59 patients had positive this MSH, MLH, or PMS2, and 41% had negative. So thereby these patients, 67% had high tumor burden. So individual clinical response rate, this is depicted for one patient. They have seen that this was the picture initially, and in the end of the 22 months, this was crystal clear, as we can see visibly, and same can be seen on MRI and PET scan, that hardly any can be seen after the treatment completion. So these patients actually almost all were node positive, as I discussed. 14 of these patients, which were assessed during the follow-up, had complete clinical remission. So this was the exciting result, which was published as we have a ray of hope of curing all patients. So these all patients actually received complete clinical response and complete they were in CR, complete response. This was the duration of response at 6.8 months. All of these patients remained to be in CR at 6.8 months. So 100% complete responses in first consecutive patients, no grade 3-4 adverse events, and no patient required further therapy. However, further therapy is required, and this actually frames a new terminology, immunoablative therapy, seeing the complete response in all the patients. And mismatch repair deficiency population of early stage disease has potential to be cured without any further treatment after this so-called immunoablative therapy. Second was panitumumab plus Folfox versus bevacizumab plus Folfox in first-line treatment. So initially, this is the paradigm trial. So they had seen what would be the best treatment to be given with Folfox in the patients who are RAS wild type. So this we are very well aware that preferably we use EGFR-based therapy, but then they looked into subset of the patients if there any further addition which can be done on the basis of this trial, and the primary endpoint was OS, and left-sided tumors were specifically evaluated, though had taken also all the right and left-sided patients. So 411 were the allocated, 404 patients in the panitumumab arm, and bevacizumab they were 407 patients. So then this was the baseline patient characteristics. They were well balanced, as we see in all these patients. And left-sided tumors, if we see that in both of the arm, 312 in the left side population on panitumumab, 292 on bevacizumab, and overall population also appear to be same. And 72% of patients had liver metastasis. And primary endpoint, first we look into the left side population. We see that panitumumab, as expected, did better as compared to bevacizumab in these patients with a hazard ratio of 0.82, p-value 0.031, which was significant. Then they saw in overall population, and they saw that still that holds good, p-value 0.03 and hazard ratio 0.84. But that doesn't mean that you start using in the right side as well. As we see in the left side population, all of these favor panitumumab arm. And if you see in the overall population, again, it seems that panitumumab is doing better than bevacizumab. But if you see the progression-free survival in left side population, it is more or less same in the overall population. Again, the hazard ratio is 1.01. So overall survival was no different. And if we see the left side population here, again, median duration of response was 13.1 months as compared to 11.2 months. And in overall population, 11.9 versus 10.9 months. So this was marginally better in the overall population. Left side population, it was far better. So summary of the adverse event were as expected. With panitumab, we had these patients who had 17.8% adverse events, and bevacizumab we had serious adverse events in 10.8%. And subsequent therapies, if the patient has received panitumab, most of these patients received bev in second line, and vice versa, the patient who had received bev received panitumab in the second line. So now we see the OS in the right-sided population. Till now, it appeared that overall population, left-sided population is doing well with panitumab. But if we see in the right-sided population, they did not derive any benefit out of panitumab. In fact, the hazard ratio was 1.09. So unlike whatever we have seen previously, that these patients are detrimental if pushed on panitumab, the right-sided tumors. In this trial, they say that it did not matter what we are using. So conclusion was left-sided overall survival 37.9 months versus 34.3 months. Overall median survival 36.2 versus 31.2. Although PFS was comparable between two arms, left-sided tumors did better on EGFR-based therapy versus bevacizumab. As we see, the left-sided PFS was 13.7 versus 13.2 months, and overall PFS was 12.9 versus 12 months. So these results support panitumab as first-line therapy for patients with RAF sites, especially so with the left-sided CRC. Now, another trial is the randomized intermittent versus continuous panitumab. So I think this is a welcoming trial because ongoing cost of panitumab is too much. And we know that after, say, 4 to 6 months, we derive maximum, depth of response with panitumab. So it was a hypothesis whether we can give a panitumab-free gap in between these patients. So this was an improved study. So what they did was in one arm, they gave FOLFIRI plus panitumab for 8 cycles, then treatment-free interval. And in the FOLFIRI, and another one was continuous. And these were the patients who were treatment naive, and they were put on this therapy combination. FOLFIRI with panitumab intermittent versus continuous. So again, primary endpoint was PFS, and apart from that, secondary endpoints were overall survivors, quality of response, and safety profile. So as I told, these were treatment naive patients. 69 on the continuous arm, 68 in the intermittent arm. And they were well balanced as far as gender is concerned or liver metastasis is concerned, and also the number of metastatic sites. So ongoing treatment in continuous, we had 10 patients who had ongoing treatment at the time of evaluation, while in intermittent, more number of patients who were still on treatment, that is 37%. And reason of discontinuation in the continuous FPCC is 17% had adverse event, because of which the disease, the treatment was discontinued. So if you see the response rate, the disease control rate was more or less same in both the arms, 94% versus 90%. And PFS, if you see the above one, FOLFIRI plus panitumab intermittent, the median PFS actually seems to be better, 17.1 months as compared to 13.2 months. Intermittent actually led to better tolerability of the treatment, and more patients continued on treatment. So why the PFS appears to be better? So according to sidedness, if we see the FOLFIRI plus this panitumab continuous, 10.7 months in right sided as compared to 7.9 months intermittent. So it was no better if we are using the continuous one. But in left side tumors, it did make a difference. As intermittent, the PFS was far better, 20.2 months as compared to 13.2 months. Safety analysis, of course, in the continuous arm, we expect more of these toxicities like skin toxicity as high as 25%. So the primary endpoint has been met with 34 patients alive and without PD at 1 year. In the intermittent arm, that is median PFS of 17.1 months. And this intermittent strategy seemed to be particularly promising for the left-sided tumor, where we see that PFS was as high as 20.2 months. And it is associated with less skin toxicity and fewer discontinuation rate. OS data is not mature yet, and the result of improved study that take on relevant value of COVID-19 pandemic area suggests that intermittent therapy would anyway be better and cost effective for these patients. So, and another one was the adjuvant chemotherapy guided by CTC. So this was, we know that this is a gray zone in stage 2, which patient should be given therapy as per the guidelines. So they took the CTC analysis, and depending on that, they decided whether the patient should go for a adjuvant therapy or not. So we know that CTC detects minimal residual disease. So it makes a sense that this stage 2 tumors are decided on the basis of the CTC DNA whether they need adjuvant therapy or not. So they randomized these patients, and few were on the standard management decision for adjuvant therapy, and some patients were put on the ctDNA guided management. And recurrent free survival was analyzed in these patients. So eligible patients were randomized and had both blood drawn at week 4 and 7 for CTC analysis. And these patients were randomized in either the traditional decision making, standard management, or the ctDNA based management. So on the basis of this standard management, more patients needed chemotherapy, 28%. However, with ctDNA guided therapy, only 15% of the patients were subjected to chemotherapy. So with that, we can see that lesser number of patients required the toxic chemotherapies if the decision is planned on the basis of ctDNA. So here, adjuvant treatment delivery in key subgroups, we see that if any of the high risk factors is seen, ctDNA guided therapy favors, because less number of patients will be needing that therapy. So recurrence-free survival was all the more same. We see that both the lines are overlapping, 91.7% versus 92.4%. So if we are taking a decision on the basis of ctDNA, this does not lead to any detrimental effect. So recurrence-free survival was more or less same whether you decide in traditional way or the ctDNA based. So recurrence-free survival in the ctDNA positive versus negative. If it is positive, even if you give chemotherapy, the outcome is poorer as compared to the ctDNA free patients who did not get chemotherapy. This was 92.5% in the favorable ctDNA negative, while 86.4% at 36 months in the ctDNA positive subgroup. So these are the recurrence-free survival. We see that the patient is ctDNA negative, then these are the patients who are having the best outcome. We see the top blue lines in both of these. And if the patient is ctDNA positive or patient is high risk according to the traditional criteria, then the outcome of these patients is poorer in these particular patients. So for patients with stage 2 colon cancer, ctDNA guided approach compared to standard of care reduce the proportion of patients needing adjuvant chemotherapy from as high as 28% to 15%. This did not compromise the recurrence-free survival, and patients with a positive ctDNA after surgery may derive recurrence-free survival benefit from adjuvant chemotherapy. So favorable 3-year RFS in patients with adjuvant chemotherapy versus low RFS in histological series if untreated. So there are other ongoing trials which will provide further insight on the optimal usage of ctDNA. So this leads to low recurrence risk without adjuvant chemotherapy if ctDNA is negative. Because 92.5%. So I think this is exciting, and maybe in coming months this will become more or less a standard of care that we will have ctDNA to guide our therapy for the treatment of these patients. With that, I'll conclude, and thanks, Dr. Denny, for involving me.
Thank you, Dr. Pankaj, for enlightening us with so many newer things which is evolving in oncology in such a short span. So starting from the dostarlimab, which is a magic drug, so-called immunoablative therapy, and right-sided versus left-sided colon issue with the newer drug, IO drug, and the ctDNA, role of ctDNA, we will be using in our routine day-to-day practice. So, so next.